Hello, everybody. This is Hani Arif, Head of Neurology Department. It's our pleasure to continue our Neuro, Ain Shams Neuro Academy. This is the sixth wave after finishing 3 of stroke. This is the third wave of multiple sclerosis. We are honored to have with here Kristen Hellwig from Bochum, Germany. She's a professor of neurology, and I will let my dear colleague who is moderating this session, Professor Magd Zakaria, the Vice President of the Neurology Department, to introduce her. After the presentation of Dr. Kristen, I will give a short presentation, and then we will take questions from the attendees. Please put your question in the chat box or Q&A, and they will be answered after the two presentations. Of course, also we are welcoming our colleagues in the OB/GYN department. I know there's some attendees from this department because our talk today is very important about pregnancy, and everybody's concerned, especially that we are having with us queen of MS and pregnancy. I guess every literature with pregnancy and MS should include Professor Kristen on it. I will let Dr. Magd to introduce Professor Kristen. Dr. Magd.
Thank you, Dr. Hani. It's our great pleasure and honor to have with us tonight Professor Kristen Hellwig. Professor Kristen Hellwig is a full professor in neurology and works as a senior consultant in the Department of Neurology, St. Joseph Hospital, Ruhr University, Bochum, Germany. And of course, as Dr. Hani said, she is the queen of pregnancy and MS. And it's a great honor to have her with us. And we will all be very much very attentive because I'm sure we will have a lot of questions for her. It's a great opportunity to have her with us. And the topic she will deliver us is women with MS. Professor Kristen.
Thank you so much. I'm also very honored to be with you. Unfortunately, not face-to-face, but thanks to the technical possibilities, it's good to have this option too. And I would like to give an update, a post-ECTRIMS update, and during the special situation during a SARS-CoV-2 pandemic, and also prepared 2 slides on SARS-CoV-2 and pregnancy. I will touch different topics, contraception. I have a couple of few slides, fertility, also assisted reproductive techniques, pregnancy and COVID-19. The largest part, of course, is pregnancy and MS medication. And finally, the postpartum period. So contraception and MS disease risk and progression. So there is not too many studies investigating the possible effect on hormonal contraception on the risk of disease progression or other adverse outcomes. And most of the studies show either a protective or a neutral effect on the risk to develop MS. You see study 6. And this was actually my study I did in my postdoc year in the US. We found that women who developed multiple sclerosis had a higher likelihood to be not pregnant in the years prior to the diagnosis and to take oral contraceptives. So now perhaps you followed a little bit on Helen Tremlett's talk, also from ECTRIMS, on the prodroma. Perhaps it's also a kind of a behavior that women just became less likely pregnant and therefore used more often contraceptives. And then there was a meta-analysis of 4 studies which suggested that the intake of oral contraception after the onset of multiple sclerosis would not worsen the disease progression, and there overall seems to appear no effect. And these data were presented 3 years ago at the ACTRIMS meeting. And you see here the forest plots. First, the risk to develop McDonald multiple sclerosis, clinical definite multiple sclerosis with 2 relapses, and the risk of confirmed EDSS of 3 here. And what you see basically that there was no risk identified between the studies. What type of contraceptions are there? So there are long-acting reversible contraceptions, which is the most effective method of contraception, as the efficacy does not rely on the compliance of the women, and a long-term contraception is provided. And then, of course, oral contraceptive pills and condoms rely on the user compliance, and correct use may result in lower efficacy. So, but this is here in Germany, at least, and I think also in other parts of the world, the most used type of contraception. And of course, the discussion is then relevant. Fortunately, we do not have many signs of teratogenicity for our multiple sclerosis drugs. It's perhaps even more important when it comes to epilepsy, because their teratogenicity is much higher, especially with valproic acid. So in general, I advise my patients to take the contraception which is best tolerated and fits best in the life profile of the patient. And there is, and this is also an important information. There are some drug interaction studies, but very few, and there are data for DMF and fingolimod, and also not for teriflunomide, but for leflunomide, that oral contraceptives are efficient. And there is a new study currently recruiting for Mavenclad, but we are one of the main centers. This was closed due to the pandemic. And we stopped recruiting. Now it opened again, so we will see. We have only a few patients, but I personally do not think that there is a relevant interaction. Then we would have had much more babies in the clinical trials. Coming to the next topic, fertility and multiple sclerosis, and given that multiple sclerosis is a disease of young women with a peak in age of being diagnosed with around 30 years, there is really not much literature out on or data publications on studies fertility and multiple sclerosis. There need to be a couple of issues considered. First, is there an impact of MS on fertility? Second, the impact of DMTs on fertility. Then third, what is with assisted reproductive techniques and their impact on multiple sclerosis? And to summarize the really small database, there is some discussion if there is an association between MS and infertility in both females and males, but probably there is no major influence on fertility. And it's also important, if somebody becomes not pregnant, it's most likely, first of all, a chance finding. If it's a woman, then 50-50 that the man has the fertility problems. And of course, there could be MS-specific problems as sexual dysfunction, spasticity, bowel and bladder disorders. Sometimes it's fear. Actually, I nearly never had the sexual dysfunction and spasticity. Perhaps once I remember it as a problem with the patient, but sometimes it's can be psychological. It was really fear, but at the end, I think it's rare. So what else is, of course, it's important that to know that, and the knowledge about fertility is not good. Many women overestimate their capability to become pregnant, but fertility declines with age, mainly due to a reduction of the ovarian reserve. So the eggs are there in baby girls from birth, and then it's in puberty, they go through a second maturation cycle, and then from then on they are reducing themselves with each cycle. And therefore, the ovarian function decreases with time. And there are methods to measure the ovarian reserve, and one is the anti-Müllerian hormone, or you can also count the antral folliculars. And the anti-Müllerian hormone levels increase during childhood, peak during puberty, then they remain constant to the age of 30, and then they decline to undetectable levels at menopause. And this even if you have an AMH of 0, it doesn't mean you cannot become pregnant, but the likelihood to become pregnant is very low. And this is, of course, the individual ovarian reserve is associated with genetic, environmental, and iatrogenic factors. In Germany, the age when women reach menopause is 51. And this is a study we did a couple of years ago, 5 years ago. We took blood from MS patients and had healthy controls. And we found, as you see here on the right, a significant reductions in AMH levels in women with multiple sclerosis compared with the healthy controls. And we also then stratified what is clinically relevant. And AMH below 0.4 nanogram per milliliter is assumed to be a very low AMH, and this was a higher proportion in females with relapsing remitting, and most of these with a very low AMH were not on any DMT. Then there was a second study 1 year later, a little bit smaller, 25 patients, and then 25 age-matched controls. Of course, age is the most important confounder, and they showed that the ovarian reserve was especially reduced in those with higher disease activity. And this is basically what is out there. And this was also an interesting study, the most recent study, but they were linking AMH levels to disability, and they found women with lower AMH levels had greater disability and greater gray matter loss than those with higher AMH levels. This is interesting, and this is the San Francisco cohort where they measured at baseline, and then they have a longitudinal biobanking and could measure it longitudinally. Coming to the point, so if we focus a situation where fertility is impacted, and we have a lot of possibilities nowadays with assisted reproductive techniques, and there are a couple of studies showing that actually there is a correlation between especially unsuccessful assisted reproductive technique and relapses. And then there was this meta-analysis, a systematic review from last year, where you see different cohorts, also data from Germany. The Argentinian cohort had the highest risk, and a newer cohort from Boston. But what you also see here in the sample size total mean is that the sample size of the different centers was really small. But it's interesting that in the most recent data here in the Boston cohort, the risk for relapses was not increased, but overall the risk for relapse was increased. Sorry. So what would you recommend? I would not disadvise to do assisted reproductive techniques. Perhaps consider the use of GnRH antagonists. It's a milder stimulation protocol with lower fluctuation of hormones. And for me, the most important advice is to choose a stable phase of the disease and choose a pregnancy-compatible disease-modifying treatment and keep the women on the disease-modifying treatment. And I will come after I have talked about the different DMTs. I will quickly cover the pandemic. So every patient with MS has a lot of questions. Can I travel? Can I work? Can I do sports? Can I have a family? Now during the pandemic, there are pandemic specific questions. Can I have a baby during the pandemic? So what we can say yes, but okay, this I wanted to share with you. It's good and that the numbers of pregnancies with women with multiple sclerosis are increasing, with what you see here indicated in the blue graph compared to women without multiple sclerosis. What should women know during the pandemic? So generally, the risk for infections is larger during pregnancy. We all know the child covers the half of the genes of the father. Therefore, pregnancy is kind of an immune suppressive state to not reject the fetus. And this goes along with a higher infection risk, and infections can be more severe during pregnancy. So for any pregnant woman, for example, an influenza vaccination is recommended. And some viruses, fortunately not SARS-CoV-2, are known to be teratogenic, for example, Zika virus or rubella. It's interesting, it's a little bit different. In Germany, there was just yesterday a study published where we did not see a risk for more severe cause of SARS-CoV-2 in our pregnant patients. Here we had 300 patients included, but the CDC, and I think the German data may be dependent that we really do a lot of testing in Germany. For example, in our hospital, we test every inpatient and every patient in our emergency room every day. So this is a couple of hundreds testing alone in our hospital, and therefore we really catch chance findings also with the pregnant patients, and not only those who contact us when they are symptomatic. So the CDC advises not to skip prenatal care appointments, but take precautions to prevent getting CDC, and really be careful, protect yourself, take the hygiene measurements, distance, hygiene, and perhaps even a kind of a little bit of shielding. Data showing more or less consistently that the preterm rate seems to be higher. And especially in China, but this was also a lot of studies from the beginning, a higher cesarean section rate. The vertical transmission, the transplacental transmission of the virus seems to be nearly zero. There are very few cases where the virus RNA was detected in the baby meanwhile, and a low neonatal death rate. And it's also uncommon that the neonate is infected, and it's also okay for mothers, even if they have COVID-19, to breastfeed under certain hygiene measurements. And with this slide now, I would like to come to the MS and pregnancy part and start with the still most relevant and general recommendations. It's really important, and I cannot repeat it often enough, that it's important to ask women if they plan to become pregnant. I think the second, when we will hear much more about vaccination in multiple sclerosis. We will hear a lot about vaccination because everybody now talks about vaccinations, but I think we should, as neurologists, we should ask the patient for the vaccination card directly when we diagnose them and then control continuously. For example, in Germany now, it's recently newly recommended that every pregnant woman is vaccinated against pertussis, as the titers are low, and we had a couple, perhaps 200-300 per year, severe pertussis infection in neonates. And this is important to know also for our monoclonal antibodies. They are transported actively from the second trimester on, from the mom to the baby, but this is also true for antibodies through vaccination. And then you can give the child an immunity from the mother. It's always good to choose safe DMTs. I will show you the most updated data in the next couple of slides. The genetic risk is low. The pregnancy complications are low. If this I really mean it, the most important recommendation is whenever you can, try to see a highly active patients before they become pregnant. And I also would add, if you have patients with aggressive MS and they plan to become pregnant in the next 3 years or something like this, do not use fingolimod, just not to become, if you have the possibility to, because you have more drugs available, not to have to switch it. And then, of course, folic acid should be intaken. And this are data from MS BASE presented this year at ECTRIMS. And what you see here is that the number of patients becoming pregnant under DMTs, the red part of this bar chart, is increasing. And this shows this is a doubling in the last 15 years, and mainly due to natalizumab and fingolimod, which was in the cohorts before nearly zero. This is also data presented by the MS BASE people. It's showing you the relapse rate, first of all, much higher in the old cohort, pre-2005. And this is like a little bit like in the PRIM study. And then here, the newer cohorts, not too much of a difference. This is a large cohort of patients with multiple sclerosis, where interestingly, there was no postpartum rebound. There's a caveat. The women in this cohort were not terribly ill. So most of them had no MS treatment, and the other 50% had injectables. But that's the good news. And then the risk for a pregnancy relapse was in this cohort by lower than 10%. If I analyze my data, it would be higher because I do not have population-based data. And here, a lot of patients without treatment, which could be identified in the databases, could be analyzed. And in contrast to this, the black graph is the old PRIM study with relapse rates as high as 1.2 in the first 6 months, first 3 months after birth. Yes, and 26 in the new cohort had a relapse in the postpartum year. Okay, what is our problem now? We need a lot of time to demonstrate safety, and the best example are the interferons, where I think we got a label update. I think you got also one in Egypt for pregnancy, and it takes, in the best case, you have 1,000 pregnancies to really better estimate a safety profile. 300 are already quite fine. Relapse data are still problematic, but are pending, but problematic for natalizumab and Gilenya. So for injectables, I just said we got in the EU label update in 2019. Both injectables and glatiramer acetate are large molecules, unlikely to cross the placental barrier. We have many pregnancies, a couple of thousand, like 3,000-4,000 pregnancies, but caveat, mainly exposed during the first trimester of pregnancy, meaning women recognizes she could be pregnant, makes a test, stops. This is median gestation week 6. So we presented some data at the ECTRIMS showing that women who stopped their interferon beta products before pregnancy had more relapses during pregnancy than those who became pregnant and stopped then. So I think we have a lot of safety data, and I think it's beneficial not to stop it before pregnancy. And also during breastfeeding, the drugs are approved. It's still a little bit of a debate, and perhaps we have time for the discussion when to continue interferons during pregnancy or Copaxone and when not. Most of my patients are actually happy to stop the drugs. I personally recommend to follow a gut feeling. If they are really scary to get a relapse, I'm totally fine to continue. If they are happy to stop the drug, that's also fine for me. This slide shows you a summary of the 3 orals. I would like to start with DMF. So in animal studies, there was reproductive toxicity, including low birth weight, but this under much higher doses of DMF. And the label tells us it's not recommended during pregnancy and should only be used. It's not contraindicated if clearly needed. So we even could continue DMF. But it's here again, the data, I will show you some more data about DMF. It's not, data during the entire pregnancy are nearly not available. Only very few women who did not recognize that they were pregnant. Teriflunomide used to have a category X. The FDA removed the categories, but it's contraindicated during pregnancy and during breastfeeding. Also some news here of a new publication this year on leflunomide. So taking together, we have more than 500 pregnancies, which is already a lot under teriflunomide and or leflunomide without seeing teratogenicity in humans. So it seems that there is a difference, and this might be explained by the different enzyme affinity of the dihydroorotate dehydrogenase in between humans and animals. So I even if women become pregnant under teriflunomide, there seems to be no major risk, but it's not recommended. It's recommended to wash it out. And fingolimod got a Dear Doctor's letter last year, and warning and a contraindication for pregnancy. And I will show you the data presented this year at ECTRIMS at a while. What is the other problem? Coming to highly active MS, it's a problem of returning disease activity, and it's clinically relevant for, I'm sorry, it's clinically relevant for natalizumab and fingolimod, and there are more relapses if natalizumab is stopped earlier before pregnancy, but still we see at least there is a relevant relapse risk during pregnancy. And this data is showing you that there is a higher risk for disability for women who take highly efficient DMTs. So the relapse risk is higher, which is the purple graph. And the risk for disability is also higher. And the problem is it's really the withdrawal of fingolimod and natalizumab and the unknown magnitude of the relapse risk. And I would like, and the disability risk. We have some ideas of the relapse risk, but we have not really good ideas of the disability risk. And I would like to present these data to you on this from this year's ECTRIMS on fingolimod. And what you see, the first group is the NSDB, is the Novartis safety database. They had 765 pregnancies. And what you see here, like in this column above, 3.3% prevalence of major malformations. If they included termination of pregnancy, medical termination of pregnancies due to fetal abnormalities, this is called TOPFA, this increased to 4.6. Then the pregnancy registry, 4.6. Last year it was higher because this year there was no major malformations. And at the end, this is not very much higher than the general population, but it is still possible that Gilenya is teratogenic, and it's also a problem with the relapse risk. And hopefully, as I said, I was unfortunately not able to come to Egypt this year. We try to analyze, and we'll do this in the following 4 to 6 months, our Gilenya data, and we also had an international collaboration to get more data on the absolute relapse and disability risk to really have a balanced risk-benefit evaluation with future moms with MS. And I personally, so the recommendation is to discontinue fingolimod 2 months prior to conception. Ziponimod with a much shorter half-life time has to be withdrawn only 10 days prior to conception, and ozanimod with different metabolites has to be withdrawn 3 months prior to a pregnancy. And for me, there might also be discussion. The question is, what should we do? Should we switch to other drugs? I prefer to switch to ocrelizumab, to Mavenclad. We are still working and do some analysis, finalizing some analysis to also estimate the magnitude of the switch relapse risk. I think we have to use short switching intervals, shorter than also recommended. For example, in our guidelines, I switch latest after 4 weeks. Normally, meanwhile, I had some so severe rebound relapses, sometimes 2-3 weeks after the last fingolimod tablet. And in case of accidental exposure, I recommend organ screening ultrasound. And I have also 2 or 3 patients who stopped Gilenya before. Then they had a severe rebound, and then they became pregnant. And here I decided to put them on natalizumab. which is, of course, a monoclonal antibody, as all of us know. And MAPS, monoclonal antibodies, are large molecules, unlikely to cross the placental barrier in the first trimester. But then on from gestation week 16, they will be actively transported and can have biological effects in the baby. And we have different recommendations for different monoclonal antibodies. 4 months for interval for alemtuzumab in the US, rituximab, ocrelizumab 6 months, very conservative in the EU, 12 months for CD20 antibodies. And there is, and I will touch on this topic later, there is a change in behavior and recommendations that breastfeeding under monoclonal antibodies becomes more and more popular. So what data do we have with natalizumab? It's, of course, I love natalizumab. It was the first MS drug where you could feel the effect because it's so efficient. Problem is when you stop it, it doesn't work anymore. We do see, and this is, we are analyzing these data now. We do see a risk for significant disability progression defined as an EDSS increase of 2 or more in around 10%. Most likely during pregnancy, but then a lot of women recover. There are some data showing that the natalizumab, that the early introduction of natalizumab might reduce the postpartum relapse risk. So what is with the exposure in the babies? Probably there is no risk if women become pregnant and stop it then. If natalizumab is continued during pregnancy, birth weight might be reduced a little bit, about 150 grams, and babies can have anemia and thrombocytopenia. Still, I would prefer the active approach. Of course, this is also a risk-benefit evaluation discussion with the mother in terms of if she thinks a risk for a severe relapse of 10% is high or not for her. I personally follow the active approach. I continue natalizumab during pregnancy. I extend the infusion intervals. I extend more than 6 weeks. Meanwhile, if the woman is of normal weight, 8 to 9 weeks, and then I stop around gestation week 34, and then I check newborns for hematological abnormalities. And breastfeeding is meanwhile okay for me. And I would really disadvise to do something like give natalizumab until, let's say, gestation week 20. And then stop it. I had a couple of severe relapses just before birth when the immune system changes, and then the MS can really explode with persistent gadolinium-enhancing lesions, even after we restarted natalizumab during pregnancy already and continued after birth. And every MS specialist know how effective natalizumab is. And why gestation week 34? So here you see the data from our registry presented 3 years ago. We have to also analyze this and publish it. What we saw, we had no relapses postpartum when women received natalizumab after gestation week 30. But we saw relapses when they stopped earlier. This year, also a new publication, data from the clinical trial program of alemtuzumab, and nearly 200 pregnancies included, all pregnancy outcomes basically in the normal range. And what you see here, and this is, interesting. So alemtuzumab is very effective. Here, relapse rate 1.6776 before alemtuzumab. Then it very nicely reduced. During pregnancy, another reduction. So even in this woman, pregnancy has still a biological effect, but then a small increase in relapse rate. I mean, not given that they started with one relapse rate 1.7 before, that's still very good. And then going back to the level pre-pregnancy. This means that we have to be humble. We have very good drugs, but we cannot cure multiple sclerosis. If we have something where nobody has a relapse postpartum, we are very close to be able to cure MS. And here again, the data on how long alemtuzumab should be stopped. And of course, the secondary autoimmune diseases can be a problem. So then we come to the CD20 pregnancies. There are a couple of more pregnancies now under ocrelizumab. It's rapidly growing. It's really worth to follow here the CD20 antibodies. And next year when we have ufatumumab, another one. So what we found, it's accepted but not available yet, where if you give the antibody during pregnancy, then the preterm risk was higher. But if women conceive between 6 months after the last infusion, it's probably safe. And I personally think that the label is too conservative. And these are the data presented this year at MS Visual. You see there are 234 pregnancies, and as it is, it's only known outcomes only with half of them, because a lot of them are still ongoing, and some of them are, of course, lost to follow up. And in the case of studies or clinical trial programs, there's often a large number also of elective termination of pregnancies. And so far, there is no risk of major malformations, no increased risk, but there might be. And I wanted to show you this one. This is not ocrelizumab, but this is rituximab, also published from this year from my mentor, Annette Langer-Gold, California, 74 pregnancies. Interesting, his a relatively high percentage of first trimester miscarriages, early miscarriages, 27%. Then everything else fine here. One perinatal stroke. There is one case report with ocrelizumab during pregnancy to avoid rebound. There's also one baby with a perinatal stroke. So I think this is something to still watch. But here you see in these graph here on the right side, the relapse risk, and this was very low, even if rituximab was not continued during pregnancy. So, and we do see a little bit the same, and we do see also a favorable effect for women with neuromyelitis optica. And as we all know, the relapses are much more severe in NMOSD patients. So I think CD20 antibodies are also a good option in active patients. And here are the recommendations I would give. And I think it's really worth to follow the literature, the conferences, because the information is growing rapidly. So then we have cladribine. I put it at the end because it's like an induction treatment, very short half-life time, only 24 hours, and a lot of safety margin around for 6 months. The official recommendation is for women and men that they do not become pregnant, procreate children 6 months after the last cycle. Meanwhile, since Mavenclad is on the market, there are around 10 exposed pregnancies of women who became pregnant during the first 6 months with no major malformation so far. so this means even with a drug like Mavenclad, if a pregnancy occurs exposed, and the women wants to keep pregnant, so far we do not have a malformation recorded. So, and this is the data we had submitted to the AAN meeting. And I think we will get more data. And of course, we will get more data on the relapse risk during pregnancy. And I have it's a case report. One woman who had a terrible first pregnancy. She stopped Gilenya. She had a couple of relapses, deteriorated to an EDSS of 4, 4.5. Then a lot of steroids. The baby stopped to grow according to the percentiles. Then she had preeclampsia, and then this little boy was delivered preterm. And we switched her after her first pregnancy to Mavenclad. And she is in her second pregnancy, and she is relapse-free. She's, I think, now gestation week 37 or 38. The baby is growing fine, no signs of preeclampsia. Baby still in. So I think if we can avoid corticosteroids, it's worth using our options. And basically, we do not have, there is a recommendation in the US to wash out teriflunomide, which is not existent in the EU. And given that the data for women looks so good, I would not recommend to stop teriflunomide. Coming to the summary of the pregnancy part, we need more information on DMT exposed pregnancies for newer drugs. Therefore, it's important to include them in a registry. There are still a couple of open questions. For example, what is the benefit for the pregnancy if we continue interference or glatiramer acetate during the entire pregnancy? We need to know a little bit more about switching, relapse risk, and best strategies, best interval for natalizumab, and more information, of course, on the CD20s and Mavenclad. This slide is showing you a large systematic review and meta-analysis. Here I pointed out the studies looking for the association between breastfeeding, postpartum relapse risk, which reported at hazard ratio, also data from our group included, and you see that the overall effect is significant and about a reduction of 40% relapses, and there is generally no need to disadvise women to breastfeed. What is, of course, we know, and some women are afraid, and we know there are relapses postpartum. So what information do we have on treatments? Basically, glatiramer acetate, you cannot, it's rapidly divided into its amino acids, so you cannot test it. Interferon beta was tested, super low relative infant dose, so the likelihood of exposure is nearly zero. This is why we got the approval in the EU, and I think you can, without restrictions, breastfeed. And on label, that's also important. Then for the monoclonal antibodies, it's ocrelizumab. There's a study underway in the US. We also contributed a lot of milk, and natalizumab, rituximab, only a very small amount of the maternal serum level. So I think that in a couple of years, we will have more women who, I predict in 5 years, all our women who want to breastfeed will do so under monoclonal antibodies if they have an active MS, at least if the baby was not born preterm. There is not much information. If the intestine is a little bit more permeable for larger molecules in these newborns. And this are also data from our group published this year. So what we did here is we followed growth. Here you see the German percentiles, boys divided by boys and girls for body weight, length, and head circumference of babies being breastfed under interferon 39 sample size or GA 34, and one both exposed to both drugs. And we also looked if they had how many were there hospitalizations, what was the antibiotic use, and growth retardations, and we did not see an effect, negative effect of exposed breastfeeding with interferon beta or GA exposure. And this study, also from our group, published by Andrea Ziplea, she's a pharmacist who did her PhD in our registry. She investigated here the safety of breastfeeding under monoclonal antibodies, and we had 17 women breastfeeding under natalizumab and 6 under CD20. And most of the natalizumab women were already exposed during the 3rd trimester of pregnancy. This is why we could measure in this baby here. I don't know if you can see my, I can use this pointer. Let me try, yes. So this baby was exposed during the last trimester of pregnancy and then was breastfed. And then you see, although it was breastfed under natalizumab, it was not detectable in the milk anymore, really giving assurance that there is no intake through the milk of a monoclonal antibody, although theoretically there are neonatal FC receptors in the intestine. Okay, and I would like to come to the end that breastfeeding is not harmful. Exclusive breastfeeding seems to be beneficial, at least in women with milder MS, and they should not be discouraged in favor of resuming their MS medications. But we will I think we will be able to combine breastfeeding in our DMTs. We are on a good way to do so with first data on injectables and monoclonal antibodies. Recommendations for cladribine is breastfeeding is okay 1 week after the last tablet. We also measured, and somehow I lost this slide because we measured and published this year that the cladribine in the breast milk, and although cladribine is very lipophilic, we only found a relative infant dose of lower than 3%, and we have a publication accepted where we measured Tecfidera in the breast milk. I mean, not DMF, but MMF, because it's very fastly metabolized to monomethyl fumarate, and the relative infant dose was also very, very low. And of course, this has to be confirmed in larger studies. And by this, I would really like to thank you, the organizers, for the invitation to this seminar. And I will be open for questions later in the Q&A session. Thank you.
Thank you very much, Professor Kirsten, for this very updated presentation about a very interesting topic that I'm sure we'll have a lot of questions after the presentation of Dr. Hani. We will keep the Q&As when Dr. Hani finishes his presentation. Now it's a pleasure to introduce my dear colleague, Professor Hani Arif, who is the head of the Neuropsychiatric Department of Ain Shams University. And he's very active in MS and in stroke. And he will be talking to us about a short presentation of think cognition. And then we will be collecting the questions from the audience. And I'm sure we will have a lot of questions today. Professor Hani?
Thank you, Dr. Magdi, for this kind introduction. And also, I would like to thank, of course, Professor Kristen for this very rich presentation she gave us. So I will go briefly through this sync cognition presentation to give more time for a Q&A session. The iceberg analogy MRI outcome may reflect underlying damage not captured actually in the MS measure. You know, of course, that relapses is only the tip of the iceberg, but underlying there is a conventional MRI measures and an even advanced MRI measure for the different grades of axonal loss and neuronal damage, which is going from the very beginning of the disease. And this will, of course, be reflected on disability progression and cognitive impairment, which is going all the time from very early beginning course of the disease. And it's proven in the literature in sense, of course, the famous paper of Trapp that was more than 2 decades ago, that brain atrophy and axonal loss is occurring very early in the disease, and this will go on. And what's important, it's this axonal loss will be reflected in 2 things. It will be reflected in the brain atrophy, and also it will be reflected in the progression of the disease and disability progression, which is, of course, will go on through the whole course of the disease. So if you can imagine, this is the appearance of the healthy controlled brain, and this is the appearance of a brain with MS patient with the same age. So we can imagine how this atrophy is going on. And of course, I guess everybody of us who are seeing patients with MS are observing this across his studies of different patients and across reviewing their MRI during evaluation of the patient in different courses of the disease. The cognitive issue affecting patients with MS can be reflected in different situations and different quality and different affection of his life. Like life satisfaction, the health-related quality of life, the quality of life itself, through, for example, the participation of patient in employment, in the relationship, in the social function, the daily activity, in the physical independence, in the leisure activities, in the mood. All these will be affected. Even the safety of the patient sometimes can be affected, like during driving and falls, and also his attitude and dealing with the disease regarding the medical decision, the medical adherence, the rehabilitation benefit, and the symptom management and the coping with the disease. So the cognition can affect a whole variety of the patient's lifestyle, and it's very important to be taken in consideration. And if we see how this cognition is deteriorating across the course of the disease, very early, it's not very apparent, it's there, but it's mild to moderate. For example, this is 0 or 2 failed subtests of BICAM test. So we can see that it's mild to moderate. It's only 8 or 18%. For example, if we go for 5 years, then we will have almost 50%. And after 10 years, definitely more than 50% of the patients will be affected severely with the cognition. And as I've just said, that brain atrophy is definitely linked to the disability progression, and this was proven in many studies. For example, in this study with the normalized cortical volume loss is correlated with the deterioration in the stable or improved. There is not much loss in stable patients, but if we go to patients with deteriorated cognition, definitely there is marked affection of the normalized cortical volume loss. How big a problem is cognitive impairment? We can see that the burden of the illness is quite high, despite it's not present in the routine evaluation. Of course, we know we all of us will measure the relapse. We will be concerned more with the relapse rate, with the radiological measurements of the activity in the MRI, and of course the EDSS score. But regarding cognition, it's not routinely done in the routine practice, despite that I guess in the last few years, everybody was interested in measuring the cognition. For example, in patients with EDSS up to 3, we can find that the cognition is definitely affected, and of course it will be increasing across the course of the disease, together with other manifestations which are not routinely also measured, like the fatigue, like the effect of productivity. And of course all these factors or these disabilities can affect the patient's life. For example, in the pwMS test of the cognitive assessment, only the decrease in one of the tests, we can see that this can decrease the percentage of employment by 50%, which is very mild. So very mild affection of the cognition can affect the employment by 50%. So this can give us a measure of the significance of the problem of cognition on the patient's life, especially that those patients are in the productive period of their life. Briefly, I will go through one of the recent drugs, the Mavenclad, and how it can improve or at least prevent the progression of the cognition across the course of the disease. In the Clarity study, which is a pivotal trial of the Mavenclad, they measured the brain atrophy through the post-hoc analysis, and it was proven that the drug can definitely decrease the progression of the cognitive deficit in comparison to the placebo. And data from the Clarity, as I just said, that Mavenclad can significantly reduce the brain atrophy versus the placebo across the course of the disease. And also in the follow-up of this study, this was also proven. We will come to the basic question: should we monitor cognition in clinical practice, which is not done routinely in most of the situation? But now I guess we are developing more and more tools, which some of them are very easy and some of them are more sophisticated and need more time. So we can start by self-reporting, then focused history, then screening tests, simple tests like SDMT, and some cognition battery, and some formal tests, which will take, of course, some time, like BCAMS. So we can assess the cognition more properly. And if we thought that this patient is needing a more formal testing, so probably we can go for this formal testing. So to test or not to test cognition, I guess the answer should be yes, because it's becoming more and more apparent that the cognition can definitely affect the quality of life of MS patients in different aspects, and it's very important to measure. And also it's very important to give drugs which can prevent the progression of the cognitive decline. I will stop here, and I will let more time for Q&A, and Dr. Magda and me will take questions. I can ask Dr. Magda to start taking questions.
Thank you very much, Professor Hani. Now, in preparation for the Q&A session, I'm not receiving the questions of the audience because we have two systems. We are on a system, the audience are on a system. Maybe Dr. Hani can collect the questions. And I will start by asking Professor Kirstein. Of course, thank you again very much for this up-to-date information about all the new recent studies and registries concerning the topic of pregnancy and lactation. What about if patients are on high efficacy medication and they have accidental pregnancy? What is your approach in such cases if patients, let's say, starting from fingolimod or ocrelizumab or even Mavenclad, and they have accidental pregnancies? How do you proceed with these patients?
Sorry, I was on mute. So I thank you for the question. This is the most difficult question. It's depending then on the patient and on her disease activity and on the drug. For fingolimod, I would stop it. I would not dare to continue it during pregnancy, also not with a contraindication. And I would then, for example, do a risk-benefit evaluation. If I, let's say, fear a high rebound risk, perhaps I would treat her with natalizumab during pregnancy. Mavenclad, we do not have much experience, but although the drug is also thought to be toxic, the first but very few 10 pregnancies did not reveal a risk or a major malformation. So I would say, okay, we do not have many data. There is a risk, but the data we have do not reveal the risk. I would, if you want to keep this pregnancy, I would recommend intense ultrasound, but I would not be worried about rebound relapses in the case of Mavenclad. And then, of course, natalizumab, there's the risk-benefit evaluation of exposing the baby to natalizumab with some risk of anemia or thrombocytopenia, or a relapse risk from perhaps 30-35% for the mother, and let's say 10% with severe relapses. So, and this is, and then from there on we have to go. Ocrelizumab, sometimes it happens. And I mean, I have to say, I do not do a pregnancy test in all my women when they come. The first time, yes, but when they come again for the ocrelizumab infusion, I do not always do pregnancy testing. So there will be a couple of pregnancies exposed. But I'm, in the worst case, the baby will be B-cell depleted and will have a higher risk for infections. And then I think we as neurologists have to talk to the pediatricians if they have to postpone vaccinations. I don't know, do you have still in Egypt BCG vaccinations?
Yes, it's very important. It's one of the essentials.
Okay, so next time when you invite me, I bring a case with me. It's a very interesting case from the UK. The mother was treated with infliximab during the entire pregnancy, and somehow everything was fine with her rheumatoid arthritis, but somehow the baby was vaccinated with the age of 3 months with BCG and died 4 weeks later with fulminant BCG, tuberculosis. And I think if you do this, the BCG, I think you have to be careful with any monoclonal antibody given during pregnancy. So we don't, for example, we don't do BCG in Germany anymore.
Dr. Hani, do you have any questions for that?
Yes, I have some of from the attendees, but I will start with one of mine. You just touched on this during your talk about whether to stop or to continue for DMT during pregnancy, and you said you can, I mean, the patient can depend on his gut feeling, but is there any, I mean, solid guidelines or criteria on which you suspect that this is a high, the patient is having a high risk of developing relapses or highly active disease, so we should go for treatment, and which treatment you would prefer? I mean, especially if the patient is at high risk, of course, apart from the injectables.
Yeah, so this was, the gut feeling was for the injectables.
For just the injectables.
Yes, gut feeling is for the injectables. So, you know, I personally, the relapse risk is low. we do not know if the continuation of the injectables reduces the postpartum relapse risk, for example. Right? So we do not have the data. So this is an open question. Overall, the relapse risk is so low that I do not have predictors. The only situation where I actively recommend to continue the injectables, let's say they had a second line drug and they were put on, de-escalated on interferon. Then I rather continue if the indication for the second line drug was disease activity. And I have some patients where I recommend to continue. This is when they had a first pregnancy with a relapse, or perhaps an early short relapse after birth. Mm-hmm. And then I continue.
But if the patient is on high efficacy treatment, I mean, if the patient is already on Gilenya or Tecfidera or some of these drugs, and he's not, he's stable on these drugs, you will stop or you will continue or you de-escalate into interference during pregnancy?
No, Tecfidera, I leave them. I leave them becoming pregnant under Tecfidera and then I stop. I think the relapse risk is low. We will also analyze these data end of next year. But I think the relapse risk is quite low. Gilenya, if they ask me, I try to switch them. I switch them on Mavenclad or CD20 antibodies or natalizumab when they want to continue, only with when they want to continue, would like to continue natalizumab during pregnancy.
Yes, but patients on Gilenya, you will not stop. You will not leave them without treatment during pregnancy.
Now, if you go to Mavenclad or CD20, I do not. Of course, I stop the treatment during pregnancy, but there will be a longer effect of the treatment.
Okay, I have a question here from Dr. Muhammad Fuad. I have a patient recently diagnosed MS for the first time with mild lesion load on MRI and plan for pregnancy. At time of diagnosis, interferon was the drug of choice to her. Should I start it and wait for pregnancy and start after delivery?
I would. How old is the patient? Did the colleague write
the? Didn't write.
Okay, if the patient is young and the likelihood of a pregnancy is high, I would say I would make a deal. I would say, okay, if she's pregnant in the next 4 to 6 months, then it's fine. If not, I would start the treatment. And if she was relapse-free during pregnancy, I would also let her breastfeed and then start the treatment after being done with breastfeeding.
Okay. There is a question from one of my dear colleagues from OB-GYN, professor of OB-GYN. He's asking about does regional, and Dr. Ayman Abu Noor, does regional anesthesia in labor carry any risk?
Yeah. I didn't know that we had obstetricians in this talk. No, it has no risk. Our data, so the mode of delivery is not correlating with the risk of postpartum relapses, and the mode of anesthesia is not correlating with the postpartum relapse risk. So any kind of anesthesia is fine.
Another question from Dr. Fuad. If the patient stopped the medication as a planning for pregnancy and then got pregnant, and during pregnancy she has more than one relapse, at that time, should I resume previous DMT?
This is a little bit dependent on the DMT. So to my opinion, this most often this happens with Tysabri. Then sometimes I resume Tysabri. So the one case I just told before, she stopped Tysabri even during pregnancy and gestational week 20, and then she got a a relapse at the end of pregnancy and we restarted Tysabri during pregnancy. This is, of course, dependent on the DMT.
Okay. Another question from Nada. I guess you partly answered this. Dr. Kristen, what are the most recent recommendations regarding dimethyl fumarate and pregnancy? Is it stopped before planning to conceive? Is it taken during pregnancy and breastfeeding? And how exactly does it affect the baby?
Okay, it is. I do not stop it before pregnancy. I only stop it when the woman is pregnant. But I do not continue DMF during pregnancy, and we need more data during breastfeeding. So the first data, it's not even available yet because it was just accepted. It has a very low content in the breast milk, but it was only 2 samples. So I think we just need some more data.
This is question, actually, it's for me. Is there predictors for early cognitive impairment in MS patients, or is it associated just with heavy load lesion, and what is the action to delay it? I guess we are really in need for markers for early cognitive impairment. Some of these markers may be clinical, especially that they are developing now some even very easy tests like SDMT, and we can assist the patients regarding the cognition easily. And also, of course, the markers for brain atrophy, it's proven. There is some debate whether this can be relied upon in routine practice, but still it's not part of the routine practice to do brain atrophy markers, whether it's with different software or whether it's specific measurements for certain parts of the brain. And also probably in the future, we might have biomarkers from the CSF or the blood, especially with the neurofilament issue. Probably this can be also a very good marker for degeneration and for probably brain atrophy. And I don't know whether also Dr. Kristen would like to add anything to this question.
Yeah, I think that this is still a very difficult. We learned a lot. We learned that it really occurs early in the disease, and I think now the key is still an effective treatment early enough. So I think the whole MS paradigm treatment changed. That we do not wait too long until patients really are in the wheelchair to take our efficient drugs. We really start early if we see there is still disease activity. And I would also, me personally, I would also, if I see there is a cognitive decline, despite, let's say, a first-line drug, I would switch. It's still, I have some patients where even the more efficient drugs do not stop the cognitive decline, but it's still worthwhile. And so far, to my knowledge, there are no good studies showing this on real-world data.
But Dr. Kristen, you can take the decision to shift a patient to another drug just because of the cognitive decline. I mean, apart from the patients having no new T2 lesions or no relapse or no definite progression of the EDSS?
Yes.
You will?
Yes.
Okay.
Then, I think I think cognitive decline is also, that's also important to mention. It's highly correlated also to depression. And therefore, it's also super important to treat the depression adequately. So that's also important too. But I would treat everything I can treat in this difficult situation as best as I can. And I have patients where I switched, yes.
There is also a question regarding if we are having a patient with transverse myelitis, pregnant woman with a transverse myelitis, any risk for spinal anesthesia or epidural?
This was not stratified in none of the studies, but given that most of a lot of our MS patients, spinal cord lesions are typical for MS, have some, at least even of the young ones, I would estimate 50%. I do not think that it's a higher risk.
Dr. Magdi, you have any questions?
Just an inquiry more than a question. If you have patients with high disease activity, they're planning to get pregnant, would you give them, let's say, fingolimod or natalizumab with strict pregnancy prevention, or due to the fact that, let's say, at least in the Middle East countries, we have a lot of accidental pregnancies, it's preferable to avoid drugs that have a rebound effect and start with other high efficacy medication?
Yeah, I think, we just talked that you can get rituximab or ocrelizumab. This could be an option, or Mavenclad instead of, do you have Mavenclad available?
Not yet. No. We have it licensed, but still not reimbursed by the Ministry of Health and the National Insurance.
So, if you have patients in the future and where you normally took the decision, do I take Gilenya or do I take natalizumab, right? You know what I mean. Then if they tell you, I want to become pregnant, I think CD20 and Mavenclad are good options. And the Mavenclad option for those where you have the feeling, okay, this could work well with Gilenya, and the CD20 option perhaps where you think, okay, there I need the strongest medications, and you would have chosen natalizumab.
For patients who have you have stopped Gilenya in the course of pregnancy, and they started to have rebounds, have you used any anti-CD20 medication during pregnancy to control the rebounds?
I considered it, but so far I always used natalizumab. There is this one case report from California. They do not mention it in the abstract, but in the text there is. They say everything is fine, but the baby had a little stroke, and then there is this other baby with a little stroke, and so perhaps it's a chance finding, but a neonatal stroke is still rare. So I would rather go for the natalizumab. Of course, I know I have the anemia, I have the thrombocytopenia. It's not perfect, but that's the problem. A rebound is a problem, and there is some risk you have to take.
Thank you.
There is a question regarding lactation. Some people actually are convinced that lactation can protect from relapses. I don't know whether this can be partly true or not. And if you allow the mother to breastfeed her baby for a while before resuming the drug, for how long would you allow her?
So I'm very happy to allow the mothers to breastfeed if they are not super highly active. If you have a pregnancy, the most important predictor for postpartum relapses are relapses during pregnancy. So if you have this pregnancy, like you stop fingolimod, you stop natalizumab, the woman had 2 relapses during pregnancy, for example, I would not recommend to breastfeed, or only breastfeed under treatment. If somebody stopped, let's say, their Tecfidera, everything was, or DMF, everything was fine during pregnancy, and she breastfeeds, and I would say, okay, she can breastfeed 4 to 6 months exclusively as recommended, and then introduce supplemental feedings. And if she stops breastfeeding then in the first year, that's also fine for me.
But does breastfeeding really protects from activity of the MS?
Yes, I mean, I showed you the results of the systematic review. It has a 40% risk reduction. We do not have these data for one single of our MS drugs.
Okay, this is very important. So it's, I don't think I have any more questions. So it's of course a great honor to have you with us, and I will remind you again with the registry. Probably we can have something with this.
Yes, I tried to figure something out for the NMOSD. I'm still working on it.
Okay, that's great. And I will let Dr. Meg to finish this session.
Thank you, Dr. Hani. Thank you very, very much, Professor Kirsten, for this very interesting evening. And it's always a pleasure and honor to see you and to hear from you. And as Dr. Hani said at the beginning, you are the textbook of pregnancy and MS. So allow us to be always in contact with you to ask you about your opinion about different things. Virtually, at least until the time comes when we are able to invite you in Egypt, and we will keep you in Egypt. You know, when you come to Egypt, we will tell them to close the borders, and we will keep you.
You know, it's really, since I'm a kid, when I was 9 years old, the exhibition of Tutanchamun was in Cologne in the museum. And somehow I didn't make it, but I saw the pictures in a magazine. And since this time, it's, you know, it's kind of a dream, but which I thought it could return into, at least also to see the pyramids in reality. But then we had SARS-CoV-2 coming along. So I've never been to Egypt.
We hope.
With the opening of the yes, you know, the Grand Egyptian Museum, definitely we will give you an invitation.
They probably will open it when things get settled down. So they will probably postpone the opening of the new Egyptian Museum, and then you will have an invitation for the Egyptian Museum.
Great. And it was an honor too for me, as always. And I really like the discussions. And this is special to the Middle East, that there are always a lot of questions.
Thank you very much. Thank you. Great pleasure and honor. Thank you.
Okay. Bye-bye. Have a good night.
Bye-bye.
Bye-bye.